Okay, so there are a lot of chapters in this review, but I do think this review kind of boils it down and tells you what you really need to know. But this first slide here just shows you, it's 25 all the way through 32. So I know that some of these slides have a lot of information on them, so we're just going to go through and make sure you know what the key terms are. So generally speaking, ventilation is just the process of breathing. So when you breathe, what are you doing? What are you breathing in and what are you breathing out?
Breathing oxygen and carbon dioxide comes out.
So you're going to breathe in oxygen, and you're going to breathe out carbon dioxide. Very good. And then the red blood cells, we talked about this. There's red blood cells is kind of like the common term or the layman's term. And do you remember the name of the medical term for a red blood cell?
Erythrocytes.
Oh, very good. Erythrocytes. So you do need to know that. So the red blood cells or the erythrocytes are the ones that carry oxygen to the tissue. So if you don't have enough red blood cells, or if you have anemia, then you're not going to have adequate oxygen delivery. And then I think you probably know this, if you're working somewhere in a healthcare system, you check their oxygen level all the time, and really it should be greater than 90%. So all of these things here, tachypnea, fast breathing, Rayleigh rhonchi, accessory muscle use, cyanosis of the nail beds, confusion and stridor. These are all things that you might see with respiratory distress. So I would recognize all of these things. If you're assessing a patient and you see any of these things, then these should be clues that they are having respiratory distress and there's something wrong with their respiratory system. And this one I don't remember talking about, but the answer is down below. So another name for the common cold is this acute coryza. So this acute coryza or the cold, you normally have, runny nose, itchy eyes, and a fever. So that's going to be different than allergies where you really don't have a fever. So you do need to, to be able to recognize like the medical term for the common cold and then how it's different than allergies. And there's a substance that babies have when they're born called surfactant, and that helps keep their lungs open. So it's important because they don't have it before 24 weeks gestation. So those really premature babies, they don't have surfactant, and they don't, even if they're 28, 29, they don't have a normal surfactant level. So that surfactant helps keep their lungs open. So they will give premature babies surfactant to help their lungs from collapsing. And then atelectasis that's just a term for a collapsed lung. So you can see atelectasis if you don't have enough surfactant, like in a premature infant, but you could also have like a blockage in your airway and you're not getting air past that blockage, and that could cause atelectasis. Somebody has mucus plugs or pneumonia. So atelectasis just remembers it's the collapse of the alveoli. So you'll see like a collapsed area of the lung. So respiratory illnesses are really common in kids. So there's a couple that you really need to remember. So RSV is the most important cause, or the most significant cause of viral pneumonia in children, in infants particularly. And then asthma is the most common chronic respiratory illness that causes a lot of school absenteeism and is a leading cause of ER visits. We mentioned cystic fibrosis in class, but I would love it if you would tell me what you guys remember about cystic fibrosis.
So it basically affects the respiratory and the digestive system.
Very good, Dwayne. Yes. And are the secretions too thick or too thin?
Too thick.
They're too thick. So the secretions are in the lungs and the digestive tract. So since they're thick, like they don't have the ability to secrete the same digestive enzymes because they block the ducts from the digestive tract. And in the lungs, they're kind of like they harbor bacteria, they stick to the sides of the lungs, and they make them more likely that they're going to catch pneumonias. So that is like the general gist of it. Some things you need to remember that, I'm going to point out, because I'm not 100% sure if I pointed out during class, it does cause infertility. So that's something that's a risk of cystic fibrosis. And just to remember that. And since they don't have the ability to produce all the digestive enzymes, they have these really foul smelling frothy stools because they're not digesting their food. And then they have loss of electrolytes. So in particular, sodium. They need a high sodium diet because they lose a lot of salt in their sweat. So there's certain things about cystic fibrosis that kind of make it different than other illnesses. It's genetically inherited. They have the thick secretions. It's both GI and lung. And then the infertility, the bulky stools, and then the salt. This is one of the few illnesses where they need a high salt diet because they lose a lot of salt in their sweat. So this word here, laryngotracheal bronchitis, you do need to remember this. This is the other name for croup. And does anyone remember the sound that's associated with croup?
Strider.
Strider. And stridor is usually on inspiration. So it's a narrowing and it's like this high pitched noise that you hear it most on inspiration, whereas asthmatics, they usually wheeze on expiration. So this laryngeal tracheobronchitis is croup, and it's associated with that stridor. It's also associated with what's called a barky cough or a barky-like cough. So laryngeal tracheal bronchitis, it can be, or croup, it can be both viral or bacterial. If it's bacterial, it has the risk of becoming what's called epiglottitis. This is this diagnosis that you always have to remember is a medical emergency. So if you ever see epiglottitis, you always have to think this is a medical emergency. As a nurse, I need to prepare for intubation. So it's upper airways, so it's a tissue right above the vocal cords. It's bacterial, it's usually H. influenza, and it's life-threatening. So if they come in, the symptoms of epiglottitis are going to be high fever, they're going to be drooling because they can't swallow, and they're kind of doing what's called tripod posturing forward because they're having a very hard time breathing. And sort of those sort of classic symptoms, you need to be thinking that it could be epiglottitis, and that's a medical emergency. They need either intubation or a trach. So those are the key points for respiratory. And then cardiac, there's a couple of different terms that I think you definitely need to know. So tachy is fast and brady is slow. So this is true. So tachypnea is a high heart rate or a high respiratory rate, and bradypnea is a low respiratory rate. You also have tachycardia and bradycardia. So just always remember that tachy is fast and brady is slow. Dys is abnormal, like dyspnea is a hard time breathing. Hypo is small. And then shunt. Do you guys remember talking about shunts, and what sorts of defects do we see cardiac shunts? So it's defined as a pattern of blood flow that's different from normal. And we talked, that's usually going to be left to right. So there's two in particular where you're definitely going to see a left to right shunt.
Oh, ASD and VSD.
Very, very good. So you think about shunts, in ASD and a VSD, there's a hole between the atrium, and the VSD, there's a hole between the two ventricles, the top chamber and the bottom chamber. So you have a shunt if it goes across that hole. And then a murmur is a sound made by blood flow. It can be because of a shunt. It can be a problem with the valve, but you hear the blood, going through the heart. And then cyanotic is bluer discoloration, and then acyanotic is normal or near normal oxygen level. And stroke volume is the amount of blood pumped out with each contraction. So these are just kind of key terms that we talk about when we talk about the cardiac system. The next couple slides are going to go over specific defects that you need to have a general knowledge of. So ASD, I think it was Antiva that knew this. So ASD is that opening between the atrium. So the atrium are these two top chambers. So this is your left atrium and this is your right atrium. So it's a hole between the left atrium and the right atrium, and you can see it. It's the mirror image. So the left side to the right side, this is going to cause a left to right shunt. So when you're thinking about cardiac, the shunts always go from high pressure to low pressure. So the left side of the heart has to pump to the body. So it has a higher pressure than the right side, which pumps to the lungs, because the lungs are a lower pressure than the entire body. So most always, unless there's something going on, like they have right-sided heart failure or severe lung disease, shunts are going to be left to right. They're going to go from the high pressure system, which is the left side, to the low pressure system that is the right side. So an ASD is a hole between the left atrium and the right atrium, and it causes a left to right shunt. And a VSD is a hole between the left ventricle and the right ventricle, and it also causes a left to right shunt. So if you have a left to right shunt, do you have increased or decreased pulmonary blood flow?
Increased.
Increased, because you're going to go from the left side to the right side. You're going to have more blood on the right side of the heart, and that in turn is going to go up into the lungs. So the three, ASD, VSD, and then also PDA, these are the three that are associated with a left to right shunt. So the PDA, this picture here shows you, this is your pulmonary artery here, and it comes off the right side of the heart and it branches to the lungs. And this is your aorta. So a PDA is a connection between the aorta and the pulmonary artery. And so the blood will come from the aorta down into the pulmonary artery, and then it goes out to the lungs. So it also is a left to right shunt, and it also causes increased pulmonary blood flow. So all three of these can they can close them in a couple of different ways. They can do surgery, or they can put a device in there, and then the PDA they can also close with a medication called indomethacin, which is the opposite of prostaglandin, so it causes that duct to close. Another defect that you need to be aware of is coarctation of the aorta. And you're going to see it here. So this is your left ventricle, this is your aorta, and you can see it narrows here. So this is the aorta is the main vessel coming off the left side of the heart that brings blood to your body. And so it's a narrowing of that main vessel. So this is the one, you know, I always think it's good to like think about what's different, so to kind of help remember the different defects. So the coarctation is the one that's associated with a blood pressure discrepancy. So where you have higher blood pressure in your arms than in your legs. And the reason is these things, you know, sticking off the aorta here, these take blood to your head and your upper body. And then here, this is where the blood's going to start going to your lower body. So since the narrowing is here after the blood goes to your head and your upper body, you're going to have less blood flow going this way. And that's why you have a blood pressure gradient where your upper extremity blood pressure is higher than your lower extremities. And it leads to congestive heart failure. So why do you think it leads to congestive heart failure? Do you think the heart has to pump harder or less hard if it's pushing against that
Harder.
resistance? Yeah. So this narrowing right here, like the blood is still getting through that narrowing, but it has to push really, really hard to push it past that narrowing. So as a result of the fact that it requires a higher stroke volume, it requires more pressure to get the blood across that narrowing, it leads to congestive heart failure. So sometimes they can balloon this open. They go to the cath lab and they put a balloon in there and they dilate it. And sometimes they have to do what's called an end-to-end anastomosis, where they cut out the narrowing and then they sew it together. So there's two defects in this list that are a little bit more complicated. One of them is tetralogy of Fallot, otherwise called a TET or a TOF. And there's four things. So there's the ventricular septal defect, there's a hole between the bottom chambers, and this has a pulmonary stenosis. So there's narrowing on the right side of the heart going out to the lungs. The aorta is pushed over. So normally the aorta should be squarely here, just getting blood from the left ventricle, but it's pushed over and getting some blood from the right ventricle. And then it has the right hypertrophy. And the reason why it has the right ventricular hypertrophy is because it's kind of like the coarctation of the aorta causes the left ventricle to pump hard, while this narrowing of the pulmonary valve, this pulmonary stenosis, causes the right ventricle to pump hard, and that causes the hypertrophy. So there's always four things associated with the tetralogy of Fallot, and it always requires surgery. This is something they cannot do in the cath lab. They're always going to have surgery, and they can have what's called a TET spell. What can you guys tell me about TET spells? Do you think they're blue or not blue when they have a TET spell, like cyanotic?
Would be blue.
They're blue. So this is one of the cyanotic lesions, and remember, so it has the pulmonary stenosis. So the blood's not able to get out very effectively on the right side to go to the lungs. So there's a priority nursing intervention for a TET spell. And it's always good to remember the things that are priority. Do you guys remember what you do when a child has a TET spell?
Aren't you supposed to like elevate them?
So you do change their position. You push their knees into their chest.
Yes, that's it. It's a knee sensor.
So when you do that, you increase their venous return. So you push blood back to the heart. So you increase the volume of blood on the right side. And then that's easier for, if there's more blood on the right side, it's easier to get over that stenotic area of the pulmonary valve, and the blood will get to the lungs. So when they have a TET spell, they kind of go limp and blue. And the thing that you do as a nurse is you put them on their back and you bend their knees and you push their knees into the chest. So you do need to know that as your priority nursing intervention if somebody has a TET spell. And then another one that's a more complicated defect that you need to recognize is the hypoplastic left heart syndrome. And we talked at the beginning, what does hypo mean?
Less small.
Less small. So hypoplastic left heart syndrome, everything on the left side is small. Your left ventricle is small, your aorta is small, everything is small. So you don't have enough, you don't have like an adequate pumping chamber on the left side, which pumps blood to your body. So they are required to have mixing, otherwise they would die. They're required to have like an ASD, because the left side is so small that it's really not functioning. So they always have associated other defects. And so it's a universally fatal heart defect if it's not treated. So they have a series of palliative surgeries. They don't go home from the hospital right after they're born. They have to stay to have their first surgery. So this is probably the most severe defect. And, a lot of times they start with the surgeries and they could end up getting heart transplants in their life because this left ventricle is so small that it's not able to adequately pump blood through their body. It's called a single ventricle defect. They're going to get blood to their lungs and to the body by their right ventricle because their left ventricle is too small. So, got to talk about some key tests. Say an aortography, they give them a dye, like an opaque dye that they can see on x-ray, and then they can look at the aorta. So they inject an opaque material and then they take x-rays. That's an aortography. Versus an echocardiogram is like an ultrasound. It uses sound waves to take pictures of the heart. And there are some key things that you would think about in terms of, so when infants go into heart failure, you would worry about that if you saw sudden weight gain, tachycardia at rest, and dyspnea. So I would definitely recognize those three things as being associated with heart failure in infants. Another thing to think about, a lot of times infants that have heart disease, they have a hard time eating. They have a hard time having enough energy to eat. So, and to prevent heart damage, after what infection do we give penicillin? There's one infection that we talked about a couple of different times. Do you guys remember what it was?
Strep.
Strep. So obviously if they're allergic to penicillin, you have to make other choices, but you give them penicillin when they have strep throat to prevent, my brain is not, rheumatic fever right here. So strep throat can cause rheumatic fever. It can cause glomerular nephritis, which is the kidney damage you get after a strep throat, otitis media, meningitis, and pneumonia. So you do need to, I would remember all of these as being associated with strep throat, and you prevent rheumatic fever in particular by making sure that the strep throat is adequately treated with a penicillin. So in this section, we also talked about blood disorders, in particular anemia. So iron deficiency anemia is the most common form of anemia. And when you have anemia, you know, you don't have the same oxygen carrying capacity because your red blood cells are what carry your oxygen. And there's also inherited forms of anemia. So the two are going to be sickle cell anemia and then the thalassemia. Those are the two inherited forms of anemia that we talked about in class. So iron deficiency anemia, you don't have enough iron to produce your hemoglobin, and the hemoglobin is the protein on your red blood cells that carry oxygen. So common nutritioncy in children, what is it commonly associated? What did children drink too much of that can cause them to have anemia?
Milk.
Milk. And then you do need to remember which foods have iron: green leafy vegetables, meat, bran, whole grains. And a hereditary disorder where blood does not clot, that is hemophilia. And if they have hemophilia, you need to replace the clotting factor that they're missing. There's different forms of hemophilia. And a hereditary blood disorder where the body cannot produce sufficient amount of adult hemoglobin, that's the thalassemia. And there's two different types. Do you guys remember the two different types of thalassemia?
It's major and minor.
Major and minor, you studied. I'm so proud of you. Yes. So major and minor. So major, you've inherited the gene from both parents, and minor, you only inherited it from one. So if you inherit it from both and you have thalassemia major, you have much more significant disease than if you have the minor. Sometimes people with minor, they don't even know that they're a carrier. And they treat this primarily with giving blood transfusions. They don't produce enough hemoglobin, and so they get repeated blood transfusions. And then the hereditary disorder where the red blood cells are misshapen, that's your sickle cell anemia. So they're in the sickle shape. They're not the normal round shape. And then hyperlipidemia is excessive fat-like substances in the blood. Hyperlipidemia then causes atherosclerosis and plaque buildup. So in kids, we start with diet and exercise modification, but it is good to be screening kids for hyperlipidemia, especially if they're a little overweight. Oh, and then for sickle cell, we talked about this. What is one of the main things that you do when they come in to the hospital and they have sickle cell? What's like a priority nursing intervention? Do you think they need IV fluid or they don't need IV fluid?
They need IV fluids.
Right. So they form clots easily because those sickle cells, they form clots more easily because of their shape. And that can lead to a sickle cell crisis, especially they get like these clot formation in their smaller vessels. So they need an IV placed and they need IV fluid. So GIGU, you know, there's your basic vomiting and diarrhea, and then there's other things that kids can be born with. So a couple things that we definitely, need to pay attention to. The first one is pyloric stenosis, and this is something that's going to require surgery. What is like the classic symptom of pyloric stenosis?
Projectile vomiting.
Projectile vomiting. So they're going to have like massive projectile vomiting, and they're hungry afterwards. They don't act sick, like they don't have a fever, they don't have diarrhea, but they really have projectile vomiting. Sometimes you can feel an olive-shaped mass in their right quadrant also. And then Meckel's diverticulum is an outpoaching in the small intestine, and it can cause rectal bleeding is the main thing that you see. And it is repaired with surgery. Appendicitis is something you can see in kids, just like you can see in adults. You need to remember that if it's ruptured, that's more severe than if it's not ruptured. They're going to need antibiotics for longer. And then Hirschsprung's, there was a couple of diseases that we talked about where they might not pass that meconium stool in the first 24 to 48 hours. And one of those is Hirschsprung's. So Hirschsprung is, it's associated with Down syndrome. So kids that have Down syndrome are more likely to have Hirschsprung's, and they don't have normal peristalsis. Their GI tract doesn't move normally because they don't have normal nerve stimulation to their colon. So sometimes they have to have that portion of the colon removed. So it can be, there's varying degrees of severity. And it is, if they do have them, their stools, they tend to kind of be prone to constipation and et cetera. So there's a range of Hirschsprung's, how severe it is. Sometimes it requires surgery and have to pull the colon up to the skin. So sometimes it's diagnosed in infancy and sometimes it's not, but this is one of the ones that for sure you worry about it if they don't pass that meconium stool in the first 24 to 48 hours. And then celiac disease. Does anyone remember celiac disease? What are they not allowed? What can they not eat if they have celiac disease?
They can't eat.
Gluten?
Yeah, they can't eat gluten. So you guys need to know, and that's the only treatment for celiac disease is they have to avoid gluten. And I would recognize, you know, we talk a lot about kids getting into medications. Is not just prescription medications that you need to be worried about. A major drug for toxicity in kids is Tylenol. Almost everyone has Tylenol in the house, and it can make you really sick. It can cause severe liver damage. So this, I would remember that Tylenol is a commonly ingested and serious medication if it's taken in too much quality or too much quantity. And we talked about this briefly, the acute glomerular nephritis. This is the sort of like allergic reaction to the strep infection that causes damage to the kidneys. And we talked about, we mentioned appendicitis. I would remember that it's, you know, associated with the right lower quadrant pain with guarding, so they don't want you to touch, and the pain is worse on rebound when your hand is coming up. And McBurney's point. McBurney's point just refers to the right lower quadrant. So McBurney's point is associated with appendicitis. That's where they experience the pain. We talked about urinary tract infections. Girls are more likely than boys because of the length of their urethra. There are certain things, you know, making sure they're peeing on a regular basis, no bladder stasis, wearing cotton underwear, wiping from front to back. And then hypospadias and epispadias. These are the two disorders of the urethra where they enter or exit the penis. And this is both hypospadias and epispadias. They normally repair them before they're a year and a half, and they request the parents not circumcise them because they can use the foreskin as part of the repair. And then this is this word that I have a terrible time pronouncing. Cryptocridism is the failure of one or both of the testicles to descend. So this can be associated with infertility because the abdominal cavity is warmer, and so the sperm don't develop the same way they would if they were outside of the body. And they can do a surgery to pull them down. So skin, this was like where we were just last week. There's a couple of different, you know, things that you should remember. I would remember the different terms that we use to describe rashes. And specifically, I'd remember that impetigo is a bacterial infection that's either staph or strep, and it causes the bullous lesion. So this is one that is definitely treated with antibiotics, and it's very contagious. Ringworm is a fungal infection. Pediculosis is a lice infestation, and this can be hair on your head. It can be pubic lice. You can have body lice. I would recognize that this word here just refers to lice. And then fungal infections, you can have like jock itch, athlete's foot. You can get fungal infections in your skin folds. And then scabies. These are mites. They're little parasites that burrow in your skin. So you'll see like lines where they burrow their eggs in your skin. Usually in between your fingers is a common place to see it. This is also very contagious. You have to treat the whole family. And then burns are important to remember. We talked about in class, if there's anything at all in the face, nose, mouth, you have to be worried about their airway. Some key things to remember are hydration, electrolyte imbalances, and they're going to need lots of carbohydrates and protein to recover from the burn. So the metabolic conditions, the two most common are going to be your diabetes and your thyroid. These are the two most common metabolic problems. What are the 3 P's that we associate with diabetes?
Would be
Polyphagia, polyuria, polydipsia.
Very good. And then they tend to have weight loss. And then they, with the polyuria, they can have wetting, like they could normally have been dry and then they start peeing at night, etc. So that when they have diabetes and they don't have enough insulin, then they have hyperglycemia, but it's also true that they could get too much insulin and then they would end up with hypoglycemia. So you need to make sure that parents know that both are possible when you have a diabetic child. So the parents also need to remember the signs of hypoglycemia, and they're here: weak, irritable, mental confusion, sweating. And then as a nurse, you need to make sure if you suspect that your child is hypoglycemic, that you give them sugar. Could be orange juice, hard candy to suck on, graham cracker, something. So as a nurse, this is one of those things that you should recognize and make sure that you treat with a quick form of sugar. If you were ever to ask a priority question, you would give them the sugar before you called the doctor. Like, you do need to notify the doctor, but you're going to, if you're worried that your patient is hypoglycemic, you're going to make sure you give them sugar. And then the diabetes insipidus, these are just two P's. This is the polyuria, polydipsia. This is the one where there's very, very brisk urine output. And so you're going to be paying attention to vital signs, in particular their blood pressure, because they're losing so much fluid because of their urine output. We didn't really talk about Cushing's syndrome in class, but it is another metabolic condition. It's overproduction of cortisol, which is produced by your adrenal glands. So you'll see symptoms similar to Cushing's syndrome in someone that takes a lot of steroids like prednisone, because those are very similar to cortisol. So they have like a moon face, thin extremities, kind of ruby red cheeks. This one is not as common as, so for sure, the two most common are going to be diabetes mellitus and hypothyroidism, followed by diabetes insipidus, and then the least common is going to be your Cushing's syndrome. We talked a little bit about immunizations. They give you acquired immunity. What are some examples of passive immunity? How do you get passive immunity?
Breastfeeding.
Breastfeeding, very good. Which lasts longer, acquired immunity or passive immunity? So it's fine if you don't know. So acquired immunity lasts longer. So you get some immunity from breast milk, but it's not going to last throughout your entire childhood. Whereas if you get appropriately immunized, you'll have some protection. So you definitely need to remember that vaccines give you acquired immunity. And there's, this DASH diet is a diet to help control hypertension. So we talked about in kids, if they're high blood pressure or high cholesterol or they're overweight, you start with dietary modification before you start adding in medication. So low fat milk products, fruits and vegetables, increase in fish and poultry, and low sodium products. These are all part of the DASH diet. And you would think about this in a kid that was hypertensive or had high cholesterol. And then erythropoietin, this is a naturally occurring hormone that regulates red blood cell production, and we can also give it synthetically. If someone is not producing enough red blood cells, we can give them, but I would remember the name of this hormone, and that its purpose in the body is to stimulate red blood cell production. So that is the basic review of the content. There's still 5 math questions. So you still need to make sure you can do pounds to kilos, figure out, like, if it's 50 milligrams per kilo, that's just 50 times their weight in kilos. You still have to be able to figure out their doses, how many milliliters based on what's available. So it'll be similar to the other math questions that you've seen, but there are 5 math questions on the test. Cool. Do you guys have any questions?
No.
No question.
No. I'm glad
Not
you
right
came
now.
today. I will post this in the announcements. And if you have any questions as you're studying, please send me a message and I'll get back to you over the weekend. All right. Good
Thank you,
luck.
Professor.
I'll see you next
Bye-bye.
week. Bye-bye.
Bye.